So in our emergency,
આ વસ્તુ મારા મગજમાં હતી કે
and of course this child would be needed the surgical intervention.
મતલબ મને એક સેટિસ્ફેક્શન એવો થયો કે હા
5 to 6 times a day
પેશન્ટ ડાયલેમામાં હતું ત્યારે એમ
in a most harrowing condition, in a most spectacular way.
બહુ સારી ટ્રીટમેન્ટ થઈ અને મજા આવી એમ.
Yeah, welcome back friends. Today here we are again with a new interesting case, so let's have a look at it. So we got a 1.5-year-old child in the casualty at around 5 p.m. and this was the presentation of a baby. Basically the child was playing, and according to the history by the parents, the child fall down while playing, and some iron rod or some spike was there pointing from the ground. We don't know what was it, but this was the history they have given, that something was protruding from the surface, and child fell on that particular pointed iron rod, and child got this type of injury. And the omentum is clearly to be seen is coming out from the abdomen, means coming out from the wound. So when the baby came, the baby was irritated, baby also had a tachycardia, and of course the pain would be there, but baby will not able to express it. The only concern here about the tachycardia was that tachycardia may in initial cases, it may be in initial cases of the shock. In grade 1 or grade 2 of the shock, the tachycardia may be there due to the blood loss, and tachycardia may also be due to the anxiety. So in initial cases of the shock, it is difficult to distinguish it, that whether it is due to the blood loss or it is due to the simple anxiety. So the child was only having a tachycardia, otherwise there was no any sign of like hemoperitoneum, or there was no any sign of like that. And of course after taking the IV line and the blood samples, we went for the X-ray of the baby, and the baby was so small that in one single plate the chest and abdomen both were covered. Right side of the chest is a relatively jet black as compared to the opposite side, as well as the shifting of the mediastinum is also noted here, and the collapsed lung is also seen.
When I have seen the patient has developed right-sided pneumothorax, and the wound suggestive of popping out of the omentum. So the object that it pierced the skin might have injured the diaphragm, so that there is a presentation of the two things, pneumothorax, and other thing is popping out of the omentum. So we go to the right-sided ICD, and after incision of the ICD, the right-sided air entry is quite good.
So now we had a question that can we manage the laparotomy of this small child in our setup or not? Of course we have no doubt in our surgical capabilities of our team, but the very enthusiastic anesthesia as well as the pediatric team is crucial in this type of cases. Both department gave us the courage that you go for the operation, we will manage the pre-op, intra-op as well as the post-op part. So due to the support of these two departments, we could proceed for the that operation. And while doing the surgery, hopefully we did not encounter any type of bowel any type of puncture to the bowel, as well as the liver was also normal, because the stab is in the right upper abdomen, so the main concern was the liver, but there was hopefully there was no trauma to the liver, just omentum was pulled out, so the omentum was taken back inside the peritoneal cavity. And here you can see that there is a 3 to 4 centimeter long right hemidiaphragm laceration is noted, and it was closed with Prolene 20 in a figure of 8 fashion and in interrupted sutures. So this was a case of a traumatic diaphragmatic injury. Regarding the traumatic diaphragmatic injury, the most cases are seen on the left side, not on the right side. In blunt trauma of the abdomen, The liver acts as a shock absorber, so the isolated injury of the right hemidiaphragm is not getting so much in the blunt abdominal trauma. And same way in a penetrating abdominal trauma, what happens, because there is a torrential bleeding when the liver gets involved, because it is liver is on the right side. So in that case there is a underrepresentation. Patient mostly dies even before reaching the operation or even before going for exploration. So these are the two reasons. The most commonly the right side of the hemidiaphragm injury are relatively less common as compared to the left hemidiaphragm, and thank God in this case the liver was not injured, otherwise it was very difficult to save the child. We also have a grading of a traumatic diaphragmatic injury, but of course these are the criteria for the adults and not for the children. I could not find the grading for the children diaphragmatic injury. So according to this criteria, and if we miniature this criteria for a baby, I think it would be the grade 3 injury in this case. Regarding the approach for the surgery, most of the time the general surgeon prefer for a midline laparotomy, but if the same case has been gone to the cardiothoracic surgeon, they prefer to go for a posterolateral thoracotomy via the 7th intercostal space incision. So it depends on the surgeon and their ability to deal with the case. But reading about the more literature and discussing with other, I could notice, I could find that in acute traumatic cases the abdomen approach is more preferred, because abdominal viscera and all thing inspection is required. And in chronic case, so while doing the coughing, sneezing or straining at the stool, the abdominal viscera get to pushed up into the thorax, and when patient presents late due to the features of this obstruction or the difficulty in breathing, and at that time the adhesion would have been developed with the pleural cavity also. So at that time the thoracotomy approach is better as compared to the only abdominal approach. So in summary, there may be different approaches or there may be debate about the different approaches to reach the injury to the diaphragm, but there is no doubt about how it should be repaired. It must be repaired with a non-absorbable suture, either nylon or Prolene, because if we take with the absorbable suture, again that gets opened up after some time and the abdominal visceral herniation will occur. We don't want to take any chance regarding that. So the non-absorbable suture, either interrupted, continuous, whatever it is, it should be done in this case. So after operation we put a 2 drain inside the abdomen, and of course the catheter and RT was inside, but the child was not extubated in the operation theater. The child was shifted in the post-operative period with a intubation, and I really thank to our pediatric department that their senior resident, their assistant professor and the senior doctors, all, I think they saw the patient around 5 to 6 times a day, and they extubated the patient in the next 24 hours, and baby was very good. He was crying and asking for the food. So this is a very good sign, and all parameters were normal. Gradually on the 3rd or 4th day we removed the one abdominal drain, and on the 6 to 7 days the column movement of the ICD was gone. We gone for an X-ray and we could see that lung has inflated very good, and the adhesion must have been developed into the pleural cavity, and that's why the column movement has stopped. So we removed the ICD. Second drain was also removed. Baby was taking everything orally, and baby happily discharged on post-operative day 6. So baby ultimately had a 2 day of ICU stay and 4 day stay in the ward. So we are happy to manage this type of case. So I fervently believe that without the crucial help of anesthesia department and pediatric department, we would not have a courage to operate this patient at our institute. and we may thought that we may send this patient to the civil hospital Ahmedabad, but we could able to manage this patient here due to the joint effort by the team.
એમાં સાહેબ ગુડ કેસ એટલા માટે હતો કારણ કે મેં આ વસ્તુ છે ને ક્લિનિકલી ડાયગ્નોઝ કરી હતી અને 4 કલાક સુધી આ વસ્તુ મારા મગજમાં હતી કે આને ડાયાફ્રામ ઇન્જરી હશે, પણ જેવું મેં ઓપન કર્યું ને તો એ મેં પ્રૂવ કરી દીધું કે યસ, એન્ડ આઈ વોઝ સેટિસ્ફાઈડ એટ ધેટ પોઈન્ટ that my diagnosis was confirmed. And when the patient discharged, we are very happy, we were, because and on that night it was very difficult for us to convince the patient that the best management can be provided here. And after the discharge, patient parents were also happy. They sir બહુ સારી ટ્રીટમેન્ટ થઈ અને મજા આવી એમ.
So after seeing all these events, joint effort by the team and healthy, happy, smiling baby discharging from our GMS hospital, I could remember one quote from the David Attenborough from the Planet Health documentary, that life can bloom in a most harrowing condition in a most spectacular way. Thank you.